Okay, I'm going to call this meeting to order at 4:03, is it? 4:02 p.m. Central Building. Go ahead and start with 1.02. Roll call, please.
All right. Jeff Balls, I'm present. Eric Diamond.
Present.
Mike Dixon.
Present.
Rachel Drake.
Present.
Vicky Cooper. Absent. Diane Lyons. Absent. Tony McMillan.
Present.
Tony Maresco. Don Miller.
Present.
Robert Munson.
Present.
We have a quorum.
Okay, thank you. So 2.01, presentation and discussion of the Washoe County School District Group Insurance Claims Experience Report as of March 2022. Information and discussion only. Lloyd?
Good afternoon, Lloyd Barnes, LP Insurance Services for the record. Good to see everyone today. So yes, let's go through our claims report for the month of March. We've got Exhibit 1 up next. There we go. Our little executive summary here for the current year. The enrollment counts, employee counts are down just slightly, down about 1.3% on the employee side. For dependent side, about almost 3%. For the month of March, running about 5.1 million, 5.179 million versus 5.6 last year. So down about 7%. Composite cost also down similarly at $735 per employee versus $786, so down about 6%. Fixed cost also down again, somewhat of that's a function somewhat of the enrollment counts. So we had a total plan costs of 5.569 versus 6 million last year. So all in all, about 6 to 7% down. Still early in the year, but we do have one claimant that has presented at above the $212,000 that we're tracking compared to the total number of 28 from last year. Looking at the next graph or the next slide, which is Exhibit 2, you can see here as we looked into March, we did have an uptick in costs. And I'm going to go to Exhibit 3 and talk a little bit further about that. Looking at the March claims, we did have a very high claims month. You can see there on line 30, about $7.5 million in total spend, which yielded a composite cost per employee on line 31 of 1,068.69, with the fixed costs added in 1,124.14. Did get some confirmation from Anthem that part of this was due to some things that they did with their claim system at the end of February, where they ended up holding some claims at the end of February that got pushed into the month of March. And I think Pamela, when she does her claims summary report, that will bear itself out, and you'll sort of see the numbers, the claim volume. This is obviously the dollars associated with that. So when you do spread those 2 months to out and basically average those out, it's much more average, but it is still up a bit. So claims costs are continuing sort of their slight upward trajectory. And again, so for over on the far right, we are down compared to last year for the first 3 months of this year compared to last year, but they have been ticking up compared to how they've been running over the full year. Exhibit beyond that, I think the exhibits that we'll go through now take us just to our large claim on Exhibit 12. And as mentioned there, we've got one claim that has emerged at about $220,000, $224,000 that we're starting to track. And this is the time of year we start to see these start to pop up and start tracking them as they accumulate the dollars throughout the year. So IBNR, oh no, I'm sorry, the that's it, I think, for my report.
Okay,
Questions?
Before we go to questions, I just want to note for the record that Tony Maresco just joined us. Thank you. Questions? Don?
So does March look like December? Because it was also spring break. And I noticed that when we have
Say that
break,
again, does March look like December
Did we-
because of that?
you know, how we always have a uptick right at December because that's a break and people
Yeah.
get things. And then March was spring break. Are we seeing that same?
Well, you got to keep in mind, this is a paid claims report, so the claims that are paid here probably happened 30 to even 60 days
Okay.
previously. So that correlation isn't necessarily direct. Prescription drugs is much more direct because
Mhm.
those process immediately. But any of the bigger stuff, hospitalization claims, a lot of your more material claims that are out there are really running arrears by 30 to 60 to 90 days. So that
Okay.
logic could very much hold, but we don't see it in the month in which it actually the break occurred.
Okay, because most of the time we see the reports from Anthem and they show that they pay within 30 days. That's why I was also.
Okay, yeah, so that's volume of claims. That's the actual claims, but the dollars when they actually work their way all the way through the system from getting seen by the provider, billed by the provider, obtained by Anthem, paid by Anthem / the district, it's usually going to be beyond the 30-day window. And I don't know, Pamela, you might be able to speak to that a little bit further. But good question, but you're usually going to see a little bit more of a lag than that, especially with the big dollars and hospitalizations and things like that.
So maybe looking at April and beginning of May, looking at April, May. For
You would see some of those seasonal trends, and the district, historically does have seasonal trends as you get to the end of, the school year, if you get to breaks, those things absolutely do result in some seasonality with your population. I think we've absolutely seen that over the years.
Any other questions for Lloyd? Okay,
All right.
thank you, Lloyd.
Thank you all.
Appreciate it. Okay, item 2.02, presentation and discussion of the Washoe County School District Group Insurance Anthem Claims Activity and Turnaround Reports as of March 2022. Welcome.
Hi, Pam Davidson with Anthem for the record. So to help you with your question, the report I'm going to read right now is the actual claims that we received during the month of March. So you'll see that March is higher than February, possibly because everyone went for that 2-week break and saw all their providers. So in the month of March, we received 16,193 claims. You'll see on the second line on the claims processed, it says 22,000. That's due to that stop that we had in place at the end of February. There was approximately 7,000 claims that moved from February and were processed in the month of March, in the beginning of March. So in the first 14 days, we technically processed 75.98% of those claims, and within 30 days, the rest of them were processed at 98.14%. If you move on down, within 60 days, 99.97% of those claims were processed and 99.98% within the 90 days. On the very bottom line, you'll see the RX claims. So the pharmacy claims for that month were 7,299. They're processed at point of service. The bottom two sections are the PPO and the HSA breakout. So out of those claims received in March, out of the 16,000 received, 14,607 were PPO and 1,586 were from the HSA plan. Does anyone have any questions on the medical? Okay, we'll move on to the dental. So the month of March on dental, we received 2,593 claims for dental. And within 14 days, 96.73% were processed. Within 30 days, the rest were processed at 100%. Any questions on the dental claims? Okay, did that answer your question on your uptick? Perfect. Okay, well, thank you.
Thank you very much, Pam. Okay. 2.03, presentation and discussion of the Washoe County School District Group Insurance Wellness Program report to cover current events and programs as of March 2022.
Okay, Laura Thurston for the record. We did finish our spring step challenge. It ended April 4th. In our last meeting, I believe I reported there's 383 participants and 88 teams. Rewards were automatically sent out to those individuals and teams through their Virgin Pulse portals as Pulse Cash. There's a little chart here that states the percentage of all teams that reached each destination. It was a destination theme. So we have close to, it doesn't quite say, but about 75% plus that went all the way to the end to Brazil, which is amazing. We traveled a total of 52,012 miles. It's basically like walking around the earth. And you'll see a breakout of the teams on average steps and things like that. We also had a Go Green Challenge through Virgin Pulse, April 11th through the 17th, in which participants could track 5 days of environmentally friendly actions to earn additional points, 200 points. And there was 192 people who participated in that. And then lastly, I wanted to introduce a new face today in our audience back there in the beautiful blue shirt. That's Mackenzie Howard. She is our new wellness coordinator. She just started. She's working part-time this month. She's finishing out her master's in public health. And so in May, middle of May, she'll be going full-time. So she will probably be presenting in our May meeting at the end of the month. So welcome, Mackenzie.
Welcome. Take something off your plate,
Yeah.
right?
Questions, anyone?
Okay. 2.04, presentation, discussion, and possible action to adopt NGO RX cost relief program, pharmacy savings program, and for specialty medication as a possible new benefit program.
Okay, this is the program that we, meaning Anthem, presented last, in our last meeting. There's a couple members that weren't here. So Kelly and Jim from Anthem, I believe, are they both on right now? I can't read that, Veronica.
Yep.
Yeah, okay.
We're both
So
here.
they're here to answer additional questions, or they can certainly go through some slides from the last presentation again as well. But the intent for today was to answer any additional questions and then give the members that weren't here the opportunity to also vote for the program. Or not for the program, one of the two.
So do we have questions that we want to ask specifically from the PowerPoint, or do you want them to do like a 30-second snippet or 30-second snippet? If they could do that, sort of that 30,000 view.
Yeah, so Kelly Dvorak with Anthem for the record. I know Jim Thorne is on as well. Jim, I think we're happy to really quickly walk through the program, the estimated savings for the district, as well as how it would work for a member, if that would be helpful for those folks that weren't able to see that last month, and we're happy to do that.
That would be great.
I think I can see you guys have the PowerPoint pulled up. Jim, I have it as well. I don't know if you want me to, if you have it pulled up, Jim, and you want to walk through.
Sure. Actually, give me a second. I can't actually see that obviously on screen, so bear with me a sec.
Sure.
I will pull that up. Good afternoon, everyone. Sorry, Jim Thorne for the record from Anthem. Yeah, I think we are on the second slide at this point, so I'll just kind of start working my way through those few slides. So the cost relief program, for those members that weren't there in the last meeting, this basically is a program that takes assistance money from specialty drug manufacturers and applies that to the cost of the medications, both at the members, on the member side and on the plan side, or Washoe County side, to really assist lowering the cost of specialty medications for the plan itself. The estimated savings that you're seeing here on slide 2 is for both the PPO and the HSA plan. There's only a handful of members on the HSA plan, and we'll get to that here shortly. But the estimated annual savings for the plan is 1.27 million of your overall specialty spend based on utilization from 2021. That does impact about 124 members as noted here within the PowerPoint. Any questions on that first slide that as we're going through this?
Don't see any.
Great, thank you. Sorry, I only have one screen, so I can only see my PowerPoint at one time, and not everybody in the room. Thank you for that. So the next slide, slide 3, is really kind of how the dollars flow through this particular program. So as we take as an example a $5,000 medication that you see here and go across the top row, quickly you can see the member cost share typically is going to be $50 on that PPO plan, since that's where most of the members are. That's how we drove these initial PowerPoint slides. And you can see the member out of pocket is as a $50 copay for that specialty medication. $50 applies to the members out of pocket or accumulator bucket for that particular medication, sorry. And then the final cost to Washoe is that $4,950. So as we kind of flow through this slide, you can see that within the $50 cost share to the member, the manufacturer is also supplying some assistance to that member cost share in the form of, just as in this example, of $45, leaving a total of $5 to the members out of pocket. Under the current setup with your benefits, the entire $50 goes towards the member accumulator or out of pocket, and the plan is still responsible for the $4,950. Sorry, go ahead. Oh, my apologies. There was a question there. Okay, so as we flow through the program towards the end here, looking at the cost relief, what we do is we take full advantage of those dollars that are available for that particular specialty medication. For ease of my math, you can see here what we did was, instead of just applying that $50 copay that you have within your benefits, we actually raised the cost share for that medication for the member to $1,000, therefore taking full advantage of the dollars that are allowed under the program and supplied to the member because of the specialty medication that they're taking today. That increases obviously the member cost share to $1,000. The assistance money that comes back is the $995 from the assistance money for that specialty medication. And bear with me here, because you'll see there that the member out of pocket is $0. What we do is we actually bring down that cost with that $5 left over down to 0 for the members. So the member actually does save money through this program. Instead of paying $50, they actually pay $0. But you can see there that we're lowering the Washoe cost on the right to $4,000 from what you see above, which is $4,950, because we raised the member portion of that cost to $1,000 initially. So what that does is allow Washoe County's responsibility to be lowered down to $4,000. So the member saves the $50 because we take full advantage of those assistance dollars. And then the cost to the plan or Washoe County drops to $4,000 from that $4,950. So for just that one particular claim, the county saves $950 in this example. I know that's a busy slide and a lot to kind of take in, but any questions for the group?
Go ahead, Jeff.
Thanks, Jim. So I guess I think I understand this, so I'm hoping you can just confirm as I walk through this. So the first step would be just taking advantage of these assistance dollars that we're not currently doing at all right now, correct?
That's correct. That's correct.
Okay. So once we take advantage or use those dollars, we can apply that to the members' costs to help them save, have 0 copay, and then whatever's remaining would go to the plan and offset the plan's cost.
Correct. It's kind of it's actually in reverse, Jeff.
Okay.
So it would be, we take those assistance dollars and apply it to the member cost share, thus lowering the plan cost. And then anything remaining, anything left over, I should say, or remaining would be written down to zero. So what we're doing is kind of lowering the upfront cost to the plan. And then on the back end, we're kind of reducing the member cost share to zero. I think we're accomplishing the same thing as the way you're explaining it.
Okay. Thank you. So we're only able to do this because the manufacturer is offering the assistance, correct?
That is correct. Yes.
Okay. So what happens if they end the assistance for a specific specialty drug? Does that member then just revert back to their old payments?
Yes, that's correct.
Okay. All right. Thank you.
You're welcome.
Thanks. Thank you, Jeff. Just before we go on, I just want to note that for the record that Diane Lyons just joined us. Any other questions? Eric Diamond?
I had presented this question at our last meeting, and I just wanted to affirm how the specialty medications are identified as being available for a program. Is that something that the member has to be aware of, or is going to be automatically identified by this program?
It's automatically identified by the program itself, but we also notify the member in various ways prior to this program starting that their drug actually does fall under the cost relief program. And if there is an adjustment to the drugs on that list, then we certainly notify the members in that situation as well.
Okay, any other questions? No more questions. You can go ahead and continue.
Okay, great. So on slide 4, what we'll see here is just kind of a summary of what we talked about, but what we do is we update the benefit design within your plan to a 30% cost share for those members that actually qualify under the cost relief program. If they don't qualify, just as we just discussed, then the cost share for that particular member does not change. Okay, the proactive outreaches we kind of touched on in slide 2, but there's 6 outreaches via, I always get this backwards, 6 telephonic outreaches and 2 letters. And if we have a valid email address, we will also send emails out. I know that's a tough one for a lot of our members today is email outreach. So, but we do outreach for all of those members. One thing that's not really on the slide deck here is that if you do accept this program for 2023, then we can also provide a list of all those members about 30 to 40 days prior to the effective date, advising who's enrolled in the program, who is still left, and then do additional outreach to those members to make sure they do get enrolled in the program. And again, as of right now, it's 124 members.
Okay, we have a question. Go ahead, Mike.
Yeah, so if I could just get some clarification, the part that I'm a little confused on. So when we talk about the cost relief program, and then on the bottom right there, we have 124 impacted members with the $0 out-of-pocket cost. When we talk about that 124 members, are those the folks that are just going to benefit from the entire program to where they're at $0 cost? Or are we saying 124 people are going to benefit from the entire cost relief plan as a whole? Like how many members will actually benefit from the cost relief plan?
124, Eric. Those are the folks that would be impacted.
Thank you.
You're welcome.
Kelly Dvorak for the record, and that is obviously a moment in time of members that we've identified on a specialty medication that qualify for the program today. We could certainly have, more or less people come 1/1/2023 as they come on a new specialty, maybe they come off of it, but based on, to give you an estimated savings, and we wouldn't imagine that number to change too drastically considering the stability of your population. But great question. It's 124 people that are on a specialty medication that would qualify for that cost relief program to lower their cost to $0.
Okay, thank you. Any other questions? Okay, you guys can go on.
Great, and thank you. The last slide is just a copy of the letter that would be sent out to the members that would qualify for the cost relief, or actually all the members. This would go out to all of the members that would be enrolled in the cost relief program. So it is obviously an enrollment that the member has to take action on, which is why we make so many outreaches. We can't just automatically enroll them in the program.
So my question would be that when I go to the pharmacy, say, and I haven't had this particular drug before, I don't know about this program or anything like that, does the insurance process it and then you guys contact me, and I pay the $50 the first time, or does it automatically come back as this is under this program?
It would process under the program as the regular benefit for let's say a new start under the program. The 124 members are currently utilizing the Ingenio specialty pharmacy. So we have to transfer specialty medications for the cost relief program to our Ingenio RX specialty pharmacy for distribution or disbursement. So it wouldn't actually process at a retail pharmacy. All of that would take place kind of in that setup process for the initial medication and getting them enrolled in the program itself. And then also making sure we have the appropriate payment information and shipping information, all that, all within the same process flow.
And you would contact the member after they've got the initial prescription and let them know about this benefit then?
Yes, that would all occur within the setup process.
Okay, thank you. Rachel, you have a question?
Yeah, so Rachel Drake, my question is, as you started, you indicated that we may have an opportunity to apply this to both PPO and HSA plans. Previously, we had discussed that this would not apply to HSA plans. Can you talk a little bit more about that change?
Absolutely. The HSA program is something that is an opportunity for you, but I think our recommendation is that you move forward with just the PPO at this point in time.
Yeah, so Rachel, this is Kelly Dvorak with for Anthem for the record. So the initial analysis is with the PPO. There is opportunity starting in January to potentially roll this out for HSA plans. However, there are some nuances that could occur for members that we can't provide first dollar coverage. Otherwise, we disqualify them from making contributions to an HSA. So we have careful for how we implement a program such as this, and it hasn't been done yet. So our recommendation, and I should back up, there are only 4 people on an HSA plan that are taking a specialty medication today. So it's a very small number. The way that their benefit works today is they can use and are using copay assistance today. The benefit to them is they are getting credit towards their accumulators for some of that cost share that for the copay assistance that they're getting, helping them reach their deductible and out-of-pocket max. With this program, if we turned that on for the HSA, that would go away, which could potentially be a detriment to that member. So our recommendation on rolling it out truly to the PPO only for 1/1/2023 is we don't have to worry about that first dollar coverage. It's really clean for a PPO member. And then we would recommend we take this back next year and vote for 1/1/2024. If it's working well for the PPO, there will be, continued details that come out around that first dollar coverage within an HSA plan. Then we tackle it at that time. So we're not taking away a benefit from the HSA folks by making them lose that accumulation. And they still get the benefit of using manufacturer assistance because it's such a small number of people. The estimate to Washoe as far as that savings doesn't really impact that number that we've shown you already. So that's the recommendation that Anthem would bring to you all.
Okay. Do we have a way to include the outreach piece to our HSA members to say, hey, you have this option available, you can sign up for it, just to make sure that they're getting, I realize it's not this program, but something similar so that they are getting that copay assistance through the manufacturer programs, which are difficult to access on one zone.
Yep. And all of those folks that are on those meds are actually already signed up and getting manufacturer assistance. So they're sort of already working that system the way that benefits them to lower their out-of-pocket costs. So they're already utilizing manufacturer assistance.
Those four are. Is there
Yep.
a way as we go through this to incorporate that? Yes, we would include that outreach for our HSA members on a similar pathway, even though it's not this exact program.
So I'll let Jim jump in here if he knows different than me. If we didn't roll out cost relief for the HSA plan as well, there wouldn't be additional outreach specific to copay assistance. However, Jim, I don't know if when somebody gets into the specialty pharmacy through Ingenio, if those reps are able to check and see, or if they know that copay assistance or manufacturer assistance could potentially be available to them.
Thanks, Kelly. And actually, that is a great question. It is part of the setup process. If they are not currently enrolled within a manufacturer assistance program, we take them down that path through the setup process when it's a brand new start for specialty medications. If it's somebody that's coming over from, say, joining Washoe and is already on that medication, to us, it kind of looks like a new start. More than likely, those folks also have their manufacturer assistance program in place because that is something that's typically set up through any PBM carrier today.
Thank
I'm
you.
not sure if that answers. Okay.
Don Echeverry.
So this says it impacts 124 members on Ingenio. How many do we have actually on Ingenio RX? This is just the ones on specialty drugs, right? We have more than that enrolled?
I'm sorry, this is Jim. Is that a overall question as far as specialty in general?
No, I mean, how are our members using this program? Because Ingenio RX is our mail-in prescriptions, correct? Because I use it.
Correct.
I'm not
Correct.
a specialty drug, I don't think. I might be, who knows? But I was wondering how many members are enrolled, and when you're looking at this 124, that's from all of our members that we have, or just the ones enrolled in Ingenio RX?
Just in the specialty portion of the benefit. So the specialty pharmacy piece itself. So mail order would be separate from this, as well as the retail pharmacy benefits.
Okay.
Most of those assistance programs from a non-specialty medication are not valid to be used within a mail order service, any mail order service, regardless of who the carrier is, but they can be used at the retail setting when folks go in to pick them up at your local pharmacy. It's a different type of assistance, but that is also out there as well. Does not fall under this cost relief program, however.
No, I understand that it doesn't fall. I was wondering how many of our, because don't we have both with you? We're adding the specialty, and that's what you're talking about, adding specialty, the specialty medicine claims, but we already have Ingenio RX for a mail-in service, correct? Because I use it through Anthem. Okay.
Yes.
I was just wondering what the usage was. Do you know our
I
overall
can-
usage?
I can check that for you really quick. Give me just a moment.
It's definitely a savings to our members to use this service over a pharmacy from
Right.
personal usage.
I kind of understand the base of your question, because actually I was just going through my text messages, and I'm using Ingenio RX, and I believe I'm a specialty medication user. And that's where I was kind of curious is, do we in some way already have a program in effect almost? And I think that kind of speaks to your question of how many people are actively using this in some form or another.
As far as actively using the benefit in 2021, it was about 79% of members used the pharmacy benefit overall.
So this is just an additional thing we can add to that service, if I'm understanding correctly.
An additional program to add to the specialty benefit, yes.
Okay, other questions? Oh, go ahead, Jeff.
I don't,
So
oh,
oh,
sorry, go
Kelly's
ahead, Jeff.
Oh, thank you. So this seems like a rare opportunity to actually be able to save both, excuse me, funds for our members and our plan. So I'm ready to make a motion if that's okay.
Before we do that, can we have just a slight bit more discussion? This is Rachel Drake. I just want to point out for those folks who were not here last month, because we didn't explicitly get into it again this month. The negative to this program, as has been explained to us, is the possibility if members do not enroll in the cost savings benefit. And in that situation, we may have members who end up with the very large portion of their prescription that they need to cover at least once until they get themselves enrolled. Now, we will have all of these outreach, all of this other stuff, but people lose papers and things happen. So just an awareness that that is a possibility, that we have members extremely angry that they have been, in their minds, overcharged for their prescription. We have ways to get them around it, but we may have that situation occur.
Thank you, Rachel.
Yes, to confirm, Rachel, your statement there would be at 30% of the cost for those folks. So good point.
Go ahead, Jeff.
I move to adopt IngenioRx Cost Relief Program, a pharmacy savings program for specialty medication as a new benefit program.
I second. Dawn Echeverry, second.
Okay, it's been moved by Jeff and seconded by Dawn Echeverry to adopt this benefit for what we go to after I make the motion, then I can call for discussion. Go ahead. But I have to state it and then I call for discussion. Go ahead.
Oh, okay. Well, what I'm wondering is this, how, if you say this is, instead of using the pharmacy, so how does it work if you are on a drug 2 through 5 schedule on the DEA list? If you don't use the pharmacy, is it the same exact way? Do you get your drugs or how?
In that situation, those particular medications would not fall under this program. That would be under typically your retail benefit. So it would not apply to the cost relief for those scheduled 2 through 5.
Thank you.
You're welcome.
Any other discussion before we take a vote? Don?
So I'm going to just speak in favor of this real quick. Not only is it a cost savings to our plan, which that's our job here, it is a cost saving to the members. And over our years of having mail-in service plans, I found IngenioRx the easiest that I've ever had to transfer to, use as a personal user, and the fact their outreach is amazing. They're not contacting you 10 days before your prescription wasn't valid anymore. Like, they've taken care of it months in advance. When they know if you're on a 3-month, they're on it 90 days ahead of time. I've been really happy with this service, and I can't say it about our previous services because mail-in kept falling off for me. So the fact that we can save our members money, save our plan money, and I found it easy. I just made a phone call. They contacted all of my different doctors at the time when we started and took care of everything for me. So I definitely think this is good for us.
Any other discussion? Seeing none, all in favor of the motion, please say aye.
Aye.
Opposed? Okay, motion passes. Okay. 2.05, discussion of included health program review for information and discussion only. Welcome.
Yes, first time. Good afternoon. It's so nice to meet all of you. My name is Krista Fisher, and I'm a client success manager at Included Health, and first time getting to see all of your lovely faces in person. So it's great to be here. Thank you. Today's agenda is really to provide an overview, since it has been a few years since the team has gotten to be in person and see all of you. So really provide that overview of the service that's in place, how we're interacting with Washoe County members today, and then what our partnership has looked like for the past few years. So we'll start with kind of just giving an overview. I know there's some new faces to this group. So if you want to jump to the next slide. For those of you who have been on the board for a while and a part of the committee, you might remember the name Grand Rounds Health. So I want to take a minute to focus on that. We are Included Health today, but our foundation and the naming of our company originally has significant purpose. So if you are familiar at all with the two first words, Grand Rounds, that was a practice where experts in the medical field used to gather around a patient and they would talk about the condition, the diagnosis, share information and expertise around what was happening and what that treatment should look like for that patient, all while talking and asking questions that were valuable to glean from that patient. And you can imagine the kind of expertise that was talked in those circles. And so the founder of our company of Grand Rounds Health really felt like it was important to allow everyone to benefit from that expertise in that circle, not just the medical individuals, to bring that out to all of us who don't have that level of medical expertise. So that's where we really got started in the field of expert opinions. And so just wanted to call attention to that. If you're familiar with that name, that's how we started. And now we're Included Health. We've really diversified and we still deliver those expert medical opinions, but we're also in new spaces as well. Virtual care. So, you know, a lot of us went and worked remotely, right? And maybe we've moved and things have changed since a pandemic happened. And virtual care was something we were already a space in, and that has grown and really become a significant part of what we do. So behavioral health, primary care, we're delivering all of that virtually today. And so our mission is really raising the standard of healthcare for everyone. And we're doing that for the included individuals, every single person giving that total care to them. So that's who we are today. And then if you jump to the next slide, the two parts of our house that I think are really important to call out and how we do what we do is one side of the house is that clinical expertise. So we have on staff clinicians, nurse practitioners, physician's assistants, and registered nurses giving and delivering that clinical care. But we also partner that with our data and our tech focus. We started in San Francisco in the tech industry. And so we really believe in the power of data and what that knowledge can provide to those clinical minds to deliver that care. So that's the two ways that we really connect and provide healthcare to our members today. So moving on, I really wanted to focus on what we're doing with Washoe County. So the service that we supply today is our expert medical opinions. And we've learned a couple things over the numerous years of providing this service. And so on the next slide, you'll see three really important areas that we've learned. So the first is that when it comes to delivering expert opinions, engaging in these complex healthcare navigations. So you talked about some of the pharmacy needs, and think about a complex diagnosis that maybe you, your family member, maybe your child has had. We know that engaging early in that complex diagnosis is really key. And then to deliver appropriate care for a complex need, you need a true expert. So the person that's in the top of their field, right? Remember that grand round circle. And then lastly, not only giving that expert opinion, but then following that with quality care. And that's where our data algorithm comes into play. And we're able to locate not only close providers, but quality providers. So providers that, you know, if you and I Googled where we should go to our primary care physician, it's going to ping us to the closest, right? The provider that's a mile down the road. But is that provider the best and quality provider for your needs? And so we really look at that when we're relaying the treatment decision from that expert to your Washoe County member. So if we jump
Can I
then,
just stop you for
Yeah.
1 second? I'd just like to invite Trustee Mayberry. He wanted to make a quick statement, and I'm sorry to interrupt your.
no problem.
Please do. I know you have to leave soon, so.
I apologize. I did be there.
No problem.
I'm Adam Mayberry. I'm trustee for District F. And we are sort of making the rounds and just thanking all of our boards and committees for the work that they do. And particularly this committee, the Group Health Insurance Committee, very run well-run committee. You should run the school board meetings. No, but truly appreciate the services that you do, because a lot of what you're talking about will then come to the board, and then we'll eventually endorse it and approve it. So it's enlightening for me as a new trustee. I was appointed in November, and so I don't know what I don't know, and so this is really a good opportunity for me to come out as well and connect with all of you. My district is District F, so it's one of the 2 at-large districts, so it's everything on the east side of the county. And but this is really a very well committee that's reflective of the organization at large. And on behalf of the Board of Trustees, again, just want to thank all of you for your service and your time and your dedication to improving the quality of the benefits for our employees here. So thank you, Mr. Chairman. Thank you all, and thank you for allowing me to interrupt. I appreciate it.
No problem.
Thank you, Trustee May. Very appreciate you being here. And
Thank you all.
it's nice when we see you guys here sometimes. Sorry to interrupt you, Christine. Go
No problem. That's a tough act to follow, though. So kind of back to what we're doing today for Washoe County members. We are providing the expert medical opinions to any member that has any type of complex diagnosis. Maybe it's an ongoing, but they're, having new treatment being recommended by their provider. And so if we jump to the next slide, just wanted to touch on that Grand Rounds motto that really we started from, and providing access to the most well-respected institutions. So this is just a quick snapshot of, we have over 4,000 experts across the nation. This is where some of the top cases that are completed, and you might recognize some of those names up there: UCSF, Mass General, Stanford, really great institutions where our experts are delivering the care to Washoe. So just to give a kind of quick overview of how we do expert medical opinions today, is that if a member came to us, we would get them in contact with one of our on-staff clinicians. So those aren't contracted, those are clinicians through Included Health. And they would begin to have just a dialogue with the member to ask what's going on, understand the issues at hand, the condition. But then a big key part of that is asking them what questions those burning questions they need answered from that expert. So we actually can go in hand not only with the records that we then collect, so that clinician would work to collect all the necessary records. Some are going to need really detailed and longer history. Others are going to need maybe the past 2 years of most recent visits to provide that expert with. But then they summarize those records, and they summarize the questions that the member is caring about getting answered. And they go and locate one of those experts from the slide you saw previously, who's the top in the field in that condition. And so they will provide the records to the expert will review, and we're pairing speed and thoroughness together. So we're not going to compromise either. We want to get that recommendation back to the member as timely as possible, especially if you understand, if you know anyone who's maybe gone through a cancer diagnosis or anything of that sort, a day matters, right? And so we're really trying to be timely, but we want to be thorough to deliver the most impactful care. And then that review is conducted and delivered back to the member by our clinician, and they're there to support them through that. So the expert would review, make the confirmation of diagnosis. Some cases are going to be a complete change of diagnosis, which you can imagine the impact of that. A lot of the cases are going to be a change in treatment. And some of them may have to do with pharmacy, as we talked earlier. So they might recommend a different prescription or a different type or different delivery method. Others are going to be, maybe they were recommended to have a surgery, and there are other more appropriate and brand new ways of treatment on the market that expert in that field is aware of, and so they can recommend a different treatment for that member, and that's relayed by our clinician. So the clinician's there to deliver it, but then there for support, any additional questions, and then we're going to move to really helping them with that treatment afterwards. So if we can go to the next slide, we look at our high quality referrals, and this is what I had mentioned earlier. So it doesn't just matter that they get that expert opinion, but we don't want them to then get treatment from a low quality provider that's close to them, right? So that near provider. So we will work to find the highest quality provider to deliver that treatment that's recommended by the expert. And this is really key in outcomes when we look at the referrals paired with our expert medical opinions. And then lastly, on the next slide, as a part of our services, we actually implemented this. It wasn't a part of the original package with Washoe County members, but we implemented this after COVID because we really felt like there needed to be an extension for members who maybe don't need the level of an expert opinion, but they need to ask those questions about what's going on in their healthcare journey or their treatment. And it's kind of, I like to refer to this is like having a doctor in the family, right? If you had a child that became a doctor, or you have an aunt, an uncle, or brother, you call them up and say, hey, this is what's going on. Like, what's your thoughts on this? This is what triage is there for. So a member would call, they would be able to connect with a licensed nurse right away. And that nurse can determine whether they maybe need to go on and speak to one of our in-staff clinicians, and they could ask those questions. There's no time limit on it. It's not a 15-minute doctor visit where time's up, out the door. We allow the time that member needs to talk through what's going on in their health journey. And then really exciting, which I'm very excited to share with today, and this is something where we are constantly innovating and looking at our service and how we relay that. And so these are some exciting improvements and innovations that we'll be looking to roll out this summer, and that will be available to Washoe County School District members. Where we have kind of heard back from members as we've worked with them and what would make this experience even better. And one thing was, for some members, they'd really like to talk directly with that expert. So in the past, and how we currently relay those, is the clinician would gather the summary, our clinician, and then meet with the expert. The expert would provide that information back, and we would relay that. But for some members, that's really important. And so we're excited to share that one of those innovations will be providing a three-way call. So the clinician will be there from our side so that member feels supported. And then they'll be able to directly interact, if they choose, on a three-way video consult with the expert directly. So they can talk to that provider at UCSF. Or wherever that expert might be. So one really exciting piece. And then the other is, for some of the cases, we've determined we don't need that entire historical context of medical records. And the experts have weighed in on this to say, hey, for these types of cases, we really just need the last 2 years. That allows us to speed up the delivery and turnaround time. And so for cases that isn't needed, we will be able to do that turnaround in 7 days. And so that really cuts down, the length of time that a member needs to wait to hear back. So really excited. Again, this is innovations that will be coming this summer that will be rolled out and available to Washoe County. And then lastly, I just wanted to share a case study that we actually have done for Washoe County member that was really impactful, and I think really speaks to the magnitude of having an expert to tell and advise. Some of these cases are not easy, and they're really life-changing, like this one. So just as a summary, this was a member that was in their mid-20s and had a pap smear done and showed signs of cervical cancer. And so thankfully, they went ahead and did a PET scan, and that showed that it hadn't spread, so it wasn't spread throughout. But the recommendation was that this member have surgery to remove her cervix instead of a full hysterectomy. And you can imagine in your mid-20s, and I can really empathize as a female, what that type of decision felt like. And so this member contacted us, and we collected the clinical history, and we had that dedicated clinician on our staff that reached out and got a hold of Dr. Chapman, who's one of our experts in oncology, and provided all the information. And in this situation, the expert reviewed all of the clinical and agreed with the diagnosis. And so unfortunately, we're not miracle workers. We're not able to change when there is cancer present. But what she did acknowledge is that this is a really tough decision for someone in their mid-20s to make, and provided her, the member, with much more information on the 2 surgeries. And actually, out of the 2, kind of recommended the hysterectomy and explained that with that, she would still be able to have her gestational carrier if she wanted to have kids by keeping her ovaries, and she would be able to, have a biological child still, where going the other route, she would most likely have a very difficult pregnancy, not be able to carry full term, and quite some complications. And so if you can see in the red, the member's response after this is, "I'm very grateful that I had this service and feel more secure moving forward. I feel the hysterectomy is a safer route and won't have the regret because I only had one doctor's opinion after getting this expert remote opinion. The team and expert were great." And so that's just one instance of the situations and the clinical care that we're providing to your members. So the last little section, I just wanted to show our 3-year partnership. So we're in year 4, but we have 3 years of partnership behind us. And our goals originally were to address some of these high cost claimants. As you understand, surgeries, cancer diagnosis, those things can be very costly on the medical plan. And so engaging with those members early, as we looked at, and then driving access to that expert care so they get the best recommended treatment, also the appropriate diagnosis, and providing a great experience during it. And so some of the year 3 highlights, and we'll jump to the next slide, I think that talks a little bit more about how we really impact savings. So this is just an example, but I'm a visual person, so this helps me, and hopefully to show you the difference. The little blue dots, the light blue dots on the upper curve, is showing a member who doesn't have access to included health and the expert opinion. So in these situations, often, as I shared, there can be wrong diagnosis. And so in this situation, this member had a diagnosis that included musculoskeletal surgery and was advised. We had the expert opinion done, and actually the diagnosis was changed. So the treatment therefore was also changed. They did not go forward with surgery. And then we, along that, provided them with therapy, quality therapists that were going to provide the treatment that the expert recommended. And so you can see the total savings there, a little over $1,200. Now this ranges. Conditions are different. So some of our average savings will range by condition. If you can imagine, neoplasms, cancers are going to be a little bit more when it comes to saving compared to, ill-defined symptoms or nervous system. So those do range. There's going to be a range in the savings that we can provide. And on the next slide, we'll look at what the 3 years have looked like for Washoe County directly. So overall, when it comes to lowering the cost, we were able, on average, for the expert medical opinions we delivered, to have a little over $8,000 per condition. And then as an average annual savings, over $350,000 for per year. And then the really important part, not that costs aren't important, but is the better health outcomes. And we're focusing on that. So out of all the expert medical opinions we delivered in the 3 years, we had 77% of those changed treatments. So really impactful in the recommendations that were delivered by the experts. And then 12% change in diagnosis. And that number is really impactful. And the reason I say that is our book of business change in diagnosis across all of our clients is 6%. For Washoe County over the 3 years, it was at 12%. And then here is just really a breakdown of how we were able to save those. So year 1, we had the most expert medical opinions delivered, 56 total. Year 2, if anyone has a wild guess what happened during year 2, the pandemic, lot of visits canceled, surgeries canceled, just members weren't seeking care, and we all understand the reason why. And then year 3, we saw that go back up, 38 expert medical opinions delivered, and you can see the return on investment there down on the last line for you. And then I did want to share just a snapshot of year 4. So year 3 ended in the end of July of 2021. So we are midway through year 4, we've completed 20 expert medical opinions, and then completed 3 high quality referrals where we actually went ahead and made that referral to the provider, a new provider for Washoe County members. And then treatment decision support, those are those calls with the on-staff clinician where maybe they didn't need the level of an expert medical opinion, but they needed support in their healthcare journey. And we currently have a little over 1,800 active registered Washoe County School District members. I won't read those all to you. This is the last slide, but I did want to just give you a little sense of the impact to the membership and what they feel after having these expert medical opinions done. The only one I would call out is on the bottom right. You went above and beyond in preparing me with everything I'm now facing. The expert opinion gave me the knowledge to be a true partner in my healthcare and treatment plan. I couldn't have gotten through this without Grand Rounds. So thank you so much for having me today. It's been a pleasure to see all of your faces and get to connect and do an overview. Thank you.
Thank you. Do we have any questions? Rachel, go ahead.
So Rachel Drake, my question is, as we're looking at local referrals, we all have a understanding that we live in the biggest little city, and experts are difficult to come by that don't have waiting lists that are 12 months, 16 months long. So are our members getting referrals to multiple physicians, specialists? I mean, just so that we can work through some of that?
Yeah, great question. So yes, especially when you're thinking of specialists, it can be challenging, the wait times available to members. So what we do in that concierge referral, if the member is open to it, is actually we would be the ones reaching out to the office and scheduling the appointment. So we would look at who has the availability. We would take that into account when we're making that referral. Some members will just prefer to have the information given to them. So we, in that situation, might give them, top 2, here's the top 2 quality providers that we would recommend to allow them to have, options if one can't see them in any timely manner. So yeah. Thank you. Yeah, absolutely.
Yeah. Eric Diamond.
You guys were previously Grand Rounds and now are
included
health. The members that registered with Grand Rounds automatically carried over, so we don't have to re-engage those same people to get going.
Absolutely, yes. Yeah. So we were really thoughtful in how we rolled that out, and that just happened at the end of March. So the microsite, the platform that you all have access to, was completely updated. There's no new logins. We communicated that and allowed members to be able to access. So even if they type in the old Grand Rounds website URL, it will automatically redirect them to the included health one. So yes.
A follow-up on that is that I know that when we originally were looking at this, and I hope I'm thinking of the right program, that we had either an unlimited use plan or a limited use plan. And what is our utilization in that?
Yeah, so you originally had a 50 case per year. So you have 50 cases that are available to use. And in the situation, where there was 56 on the first one, those are just additionally billed outside of the 50.
Okay.
Any other questions? Okay. Thank you very much.
Thank you so much.
I appreciate the presentation. Okay, 2.06, presentation and discussion of the Virgin Pulse Wellness Portal Annual Program Review. For information and discussion.
Good afternoon. This is Shane Callahan with Virgin Pulse for the record. I'm going to do my best to walk through the slides here. I can't quite see them on your screen, but I'm just going to pull those up quickly. And while I'm doing that, thank you all very much for your time today. Okay. So the first slide I'm sharing just presents that we're going to be examining the Washoe County School District Program Review with Virgin Pulse. Our primary focus is just going to be on the 2021 plan year and some data from that year. And just for those of you who, it's been a little while since I've been a part of the insurance committee conversation. I just want to, reiterate that Virgin Pulse is the program that houses, your well-being program, health content, STEPS challenges, as Laura Thurston was speaking to earlier. We also house navigation of benefits and various partners that you work with from a health perspective as well. And today, my focus will just be on showcasing the program performance of 2021. So if you could go to the next slide, our agenda, I'll just share a little bit of what's to be expected here. So first, I'd just like to showcase some program highlights at a high level for Washoe County. Next, we'll review an executive dashboard analysis of program performance before shifting into more of a focus on population health and biometrics analysis. And then before we wrap up today, I also have a claims data assessment to share with you all as well. So with that being said, we can go to our next slide. It should be titled Washoe County School District Highlights 2021 and 22. And so what I have done here is try to organize some achievements and some highlights of this period into 3 categories. The first being program engagement, the second being culture and STEPS challenges and corporate challenges, and the third being more of a specific to health focus. So I'll walk through each of these, and I welcome questions, of course, along the way. So first and foremost, program design is how we obviously design the well-being program, and that can be done in a way that is very much tailored to your organization. And what we've done leading into your most recent program year, the one we're in now, was made some program design changes that are most in line with the Virgin Pulse best practices. What that could mean, what that does mean is more actionable activities that are health and well-being focused, that allow for more of a depth and breadth for the member to choose from. That could be more frequency of activities such as tracking steps, and that could be brand new activities around digital coaching, for example. And we can dive into that more along the way today as well. With those changes, what we noticed was a 24% increase in average monthly engagement for your population that's enrolled in the platform. Another highlight for engagement here is that 84% of your enrolled population completed the health assessment on our platform, of which we have some data we'll look closer at soon. And then finally, 10%, we have 10% higher level attainment for members who track BMI on the platform. What that means is the Virgin Pulse program is designed to achieve points for engaging in healthy activities, which allows you to cross through different levels and thresholds. There are 4 levels. And we're seeing that there's a 10% higher level attainment for those who are tracking their BMI on the platform. Shifting gears into the culture and STEPS challenges focus here, I just want to highlight that Washoe County did opt into our promoted healthy habit challenges, which are deployed on a monthly basis. And so Laura had referred to one of those earlier today as well. And we're seeing some positive engagement with those, and it's definitely a best practice with our program. We also deployed 2 STEPS challenges in 2021, as well as 1 Spotlight Challenge. And a Spotlight Challenge, for those of you who may not know, is a new type of challenge in our library of challenges that allows for a social and health experience that is not just specific to STEPS and activity. So this Spotlight Challenge, for example, was mindfulness focused. And then finally, we noticed a 3,977 average step increase for inactive members during the STEPS challenges when those challenges were deployed, which is a very healthy increase in average steps for that segment. Finally, with the health focus here, I just want to note that we added a new NCQA certified health check HRA, which is the health assessment that the Washoe County population completes on the platform. And that health check is what is going to inform some of the rest of their wellness journey experience in the Virgin Pulse platform. We also added action rewards for completing the HRA, which is that health check, as well as completing a biometric screening. So those are 2 very much focal activities for this program. And therefore, when I say we created action rewards, it means that we created a menu. It is a very small menu that highlights those 2 rewards in a way that is easily accessible for your members, and therefore we saw higher engagement with those as well. Finally, here in the health section, I want to note that we were able to integrate claims data, working closely with Anthem, And so that's going to be an important part of the future of our partnership as well. I can speak some more to that at a later point in this conversation. And then finally here, 15% of your eligible population was tracking biometrics data in the 2021 plan year. And so again, that's at a pretty high level, but just I find it helpful to highlight some achievements at the forefront of this conversation. And so before I move on to the executive dashboard, would love to pause and see if anyone has any questions for me.
Are there any questions so far? Don't see any questions right now.
Okay, thank you very much. In that case, we can move on to slide titled Executive Dashboard. And this slide is really a high-level outlook at your program performance in the given period here. There's various different modules that we can explore around program performance. And the first is the top left-hand corner, your enrollment and engagement metrics. And so we're seeing that 91% of your eligible population is enrolled on the platform, which is excellent, as you can see, compared to our benchmark comparison of 54%. And we also are noticing a 57% average monthly program engagement, which is a significant increase from the previous period. You'll see that 24% on the right-hand side of the number, 57%. That's an indicator of the change since the previous period that we tracked this information. And as you can see, that's not only an increase, but also now exceeds the benchmark comparison of 45%. Additionally, we can take, again, at a high level overview here, look at some of the other areas of program performance. 17% of members are earning an incentive on the platform. 21% of members have at least one social connection on the platform. So that's really essentially having a friend on the platform, and that can play an important role in the overall experience and you know, steps challenges and other challenges, for example. On the bottom left-hand corner, again, keeping it high level here, health assessment and biometrics. So we saw that 84% of your members that are enrolled completed the HRA or the health assessment on the platform. And we also have 84% of your members tracking biometric data on the platform as well. Finally, on this slide, just to focus on that challenges portion here, we're looking at 9% participation on average throughout your corporate steps challenges or organizational steps challenges in the given period, which, as you can see, is right around the ballpark of what we see across our benchmark comparison or book of business comparison, lagging slightly behind. So hopefully we can use some creative tactics to drive that participation further up in the future. And so what I have next is a series of slides that dive a little deeper. Before I dive any deeper, does anyone have any questions for me?
Any questions? Nope, go ahead.
Perfect. Thank you so much. So my next slide should be titled Engagement Dashboard. And so this is a helpful view of a 12-month period in 2021 in which your program, as it runs with Virgin Pulse, is off calendar year cycle, right? So you refresh your program in August of 2021. And in that period of time, working with the administrators on the Washoe County side, we made some changes to your program design, as I had mentioned earlier, that does align some more with some of our best practices. You know, that can be everything from the library of action rewards that exists to earn points and therefore earn levels and cash. That could also look like just different ways of engaging with the platform. We can host announcement cards that showcase other events that are happening on site at Washoe County or nearby as well. So my point here on this slide is just to demonstrate with some of those program design changes, we were able to see a significant uptick in engagement, which in this case is defined as monthly engagement starting in August and continuing into 2022. My next slide is focused on steps challenges. And so this should be corporate challenge number 1, which is Step into Paradise. And so really what we can see here is that 10% of members participated in this corporate challenge in March into April of 2021. And I think what's really important and powerful here on this slide is not only looking at the top chart that identifies activity trends for all members that participated. So you can see there was an amount of participation, or excuse me, activity for those members during the challenge that was 12,000, almost 13,000 steps on average. Prior to that, they were tracking more an average of 8 to 9,000. And then you can see on this slide that after that period, after the challenge was completed, they did drop down to closer to 10,000. However, it's still above that that threshold they were at previously. So that's one part of the story here. But the other part of it is on the second chart, which is really only focused on those members that were considered inactive prior to the challenge. What that means is they were tracking less than 5,000 daily steps, and therefore they fell into that inactive category. And so in this steps challenge, we can see that they were tracking below 4,000 steps, closer to 3,500 per day on average, which climbed up above 8,000 steps per day during the challenge. And then after the challenge, although it fell down to what looks like on my slide here, about 4,900, right, closer to that 5,000 daily step threshold, you can see that there was an impact not only during the challenge, but a sustained effect after the challenge as well. And if you can proceed to the next slide, this should showcase the second steps challenge that we deployed called the Fall Step-A-Thon. So clearly this one was in the fall, October into November. And really what we see here, again, we see about 8% participation, so a little bit less participation in this challenge. However, we're also seeing a similar story, I think, here in the activity trends for all members and for the lower active members, where there is a very measurable increase during a steps challenge. And while it drops off afterwards, there is still a sustained impact on members, in particular those members that are considered inactive. And so next, I'm just going to shift gears towards the HRA, that health assessment. Before I do so, are there any questions for me?
Questions? No, go ahead and continue.
Okay, thank you. So my next slide should be titled Health Assessment, Health Check. And so what this slide is telling us is that 6,778 of your members completed at least one question in this health assessment in the given period. And what's really important here is typically what I do as your client success manager is take a close look here at the risk distribution. So we can track risk distribution across nutrition, weight, physical activity, stress, and sleep. And in particular, we can take a look at, in these categories, where are members tracking suboptimally or where they could improve with relation to these different risk areas. And so obviously this is self-attested information coming from the member completing their health check, which is an important thing to consider. But it's clear here that the suboptimal categories stand out as weight and physical activity in these instances, followed by stress as well, just not quite as high as weight and physical activity. And really what that tells me as someone who's working with the, with Laura and the rest of the Washoe County team is, when we consider program strategy, where do we want to focus more targeted campaigns? Because the product is going to do its job in terms of completion of the health check. A member is going to get a profile of what their health looks like and where to go next with the platform. But we as administrators also have some flexibility to serve up more targeted campaigns. Steps Challenge is a good example of that. We also can apply double points, for example, towards certain areas of the platform that are more mental health focused. Maybe they're more activity focused or nutrition focused as well. And so when I look at this slide, it's telling me that, okay, we can try to continue serving up these steps challenges in a way to help these members that are suboptimal with weight and physical activity to close those gaps as it relates to how they feel. And of course, the way we see it at Virgin Pulse is that this entire experience with their health is a holistic experience. So if there is a stress issue that is mental health related on one side, it's always bringing in the focus around nutrition, physical activity, and sleep. All of those elements are going to support greater health outcomes as well. So before I move on, are there any questions or comments for me on the health assessment?
Any questions before going to the biometrics? No, doesn't look like it.
Okay. Thanks so much. So I should have a biometrics report title slide here, and we can proceed through that into the title, or excuse me, the slide titled Biometric Summary. And so what we have here today is an overview of biometrics, a report that we can generate on the Virgin Pulse side. We see that 15% of your population are reporting any biometric measurements. So this again, this is validated data. This is coming to us from specialty health primarily, from those screenings that your members do to earn points on our platform for one thing, but also to house that information that you see on the right-hand side here from BMI, blood pressure, glucose, all these different elements, so that we can help them personalize their experience as it relates to health and well-being. So what I'll do next is just go through each slide. I have a handful of slides here that are biometric in focus, and walk you through what we're seeing here. And you should see the BMI slide first, which is going to combine risk distribution and level attainment. And I'll tell you some more about what that means right now as well. So on the left-hand side of the screen, you should see BMI distribution. And so what we're able to do is sort of stratify of the members that have with BMI information that we've received. We can see that 26% of them fall into the obese category, 35% fall into the overweight category, and 39% into the more normal or underweight category. And I think what's really helpful about this slide is not only the risk distribution, but what's also on the right-hand side, which is essentially telling us level attainment for members that fall into those specific cohorts, so to speak. So you can see how there's a focus on missing data, normal BMI, overweight BMI, and obese. And really what this slide is telling us is that when we have BMI data for these members, they're more effective at engaging with the platform and moving through the levels with those actions. And in particular, we're seeing that not just with the those with normal BMI, but also with the overweight and obese designations as well. So I think it's helpful to see that not only is this program being engaged with by those members of your population that are healthy, which is great, but also those members that are falling into potentially more risky distribution areas. And so what I'll do next is walk through each of these slides as it relates to different biometric measurements. The next one should be blood pressure, in which we can see that 34% of the population falls into the hypertensive category, 40% pre-hypertensive, and 27% as normal. And this is accompanied as well by the level attainment distribution on the right-hand side of those members that fall into those specific cohorts. So again, we can see that there is a consistent level attainment through level 0, 1, 2, 3, and 4. In this case, it's more of levels 0, 1, 2, and 3. So we're seeing engagement from the pre-hypertensive and the hypertensive group as well. My next slide is on fasting glucose. And so here we can see that there's a 7% designation as diabetic, 48% as pre-diabetic, and 44% normal. And on the right-hand side of the screen, again, similar story here. Mostly with respect to the pre-diabetic group, there's a stronger level attainment and therefore stronger engagement with the platform, not as much with the diabetic in this particular instance. My next slide is focused on HDL cholesterol. Again, we can see the risk distribution of 11% as low, 45% as borderline low, 44% as normal, followed by the accompanied level attainment and engagement with the platform for those members. And as I'm walking through this, just something to be thinking about here is what I'm seeing on the Virgin Pulse side is not only are we seeing, I think, an increase in engagement with this, which is very positive for your population year over year, but we're also, I think we have really more information about the health of your population than ever before. And that's in the form of that health assessment that we saw already. That's in this biometric data analysis, which hopefully we can grow beyond 15% in the coming program year. And it's also going to be showcased in the claims area as well. And so as I'm walking through this, I just want to highlight that while we're seeing this engagement as positive, we can start to think about how else can we serve up content. Maybe there are new partners or benefits or tools that can close gaps related to these risk distributions. Maybe it's diabetes, maybe it's cholesterol, BMI, so on and so forth. So I just wanted to mention that as I walk through this. Currently, I'm looking at the the LDL slide in the LDL cholesterol. So in this instance, we see 3% as high LDL, 15% borderline high, 28% as moderate, and 54% as normal. Again, followed by the level attainment, which in this case, we're seeing most engagement with the normal population, and therefore there could be some opportunity to close some gaps with the borderline high and high population, or segment, I should say. And then finally, actually, this is second to last biometric slide here. This is total cholesterol. So we can see 6% as high, 24% as borderline high, and 70% as normal, accompanied by level attainment metrics as well. And then finally, as far as the biometric data here, triglycerides, we can see on the risk distribution, 11% high risk, 11% borderline high risk, and 77% normal. And so again, on the right-hand side, we can take a closer look as well at level attainment for those particular segments as well. So as we sift through some of the biometric data, I also wanted to make sure you had a sense of what program engagement looked like for some of these cohorts, as we can sort of pull those out from your data. And so with that being said, before I move on to the next topic, would love to see or hear any questions if you have them.
Any questions? Don't see any at the moment.
Okay. Thank you so much. So next you should see a slide titled Opportunity Assessment for Washoe County School District. And I want to mention off the forefront, Virgin Pulse as a, a very progressive software technology company involved in well-being, we're often exploring acquisitions of other companies that can bring value to our product and therefore bring value to our clients as well. And so Advanced Plan for Health is an example of one of those acquisitions that we made about a year ago in an effort to really amplify what we can do with our clients from a claims reporting perspective. And so I say that because we were able to successfully integrate claims with Anthem over a year ago, which is very exciting for the program. And before I move on, I want to mention that really that means a couple of different things. First, there is the member benefit of which, when and if the timing is right for this group, we can allow for that claims data to influence the platform and the program to help personalize that experience even further for members. We're not quite there yet. So just for context, that's not something we're actively doing, but that's an opportunity with this data. But what we are doing is the second focus, which is more of the reporting focus, in which we can take a dive into some of the claims trends that we can analyze with a Virgin Pulse lens, for example. And so before I jump any further, I just want to mention that there is a team of experts that work very close to this reporting on the Virgin Pulse side. And the one of them in particular that has worked with me with the Washoe County report was unable to join this conversation. And so what I prepared today is a bit of a high-level overview. It's a bit of a tip of the iceberg, so to speak, of that reporting. And so I have some training on it. I just wanted to mention that if there are certain questions that go a certain depth, I may just need to take those back and bring them back to you in a future conversation. And I'll go to my next slide here, which is just to clarify the report purpose here. This is an opportunity assessment. And the purpose here is to serve as a tool to aid in evaluating and executing strategy related to, it could be the Virgin Pulse program or greater programming. The report provides an in-depth view of key measures for current and prior timeframes and compares them to norms and national benchmarks as well. And so we can now move into the next slide, which is titled Health Plan Performance Summary. And going back to the comment on the earlier slide about timeframes, what we're doing is evaluating the prior plan year of 2020 against the plan year of 2021, because we're looking at this data in 12-month increments. And so really what this slide is showcasing is trends with claims for those members who are enrolled in the Virgin Pulse platform. And so what we can see here, the primary takeaway here is that there's an 8% increase in compliance and care gaps for the members that are enrolled on the Virgin Pulse platform. There's certainly an element of what we do on Virgin Pulse that we have action rewards that are tied to preventive care, for example. So that could be your skin check, flu shot, immunizations, and so on. And so we're serving those up on the Virgin Pulse platform in an effort to help you close those gaps. And so with this reporting, we want to try to evaluate over time what kind of an impact that we are supporting on that front. And so if you go to the next slide, you'll notice that we've segmented out those members who are not enrolled on the Virgin Pulse platform. And you have quite a few that are. But on this slide, we can see that the compliance direction is quite a bit different here in the negative trend year over year in 2021, in 2020, heading into 2021. And so at a high level, what we're looking at here is chronic disease claims and preventive claims as well. And that's how we're getting to some of these figures in compliance. My next slide, and I have a couple of more here, is really more preventive care gap analysis, more preventive care in focus here. And so what this is showing is this is also focused entirely on the enrolled in Virgin Pulse population here, specifically. And so what we're seeing here is that there is the trends with this group in terms of the gaps in care completion of these different areas, so that we have preventive care office visits, outpatient or telehealth, cancer screenings, colon screenings, and so on. We're seeing that they are exceeding the preventive care gaps compared to your whole population. So we're seeing a greater preventive care performance in terms of the gaps for those who are enrolled in the Virgin Pulse platform. And then my final slide is really more focused on the predictive modeling elements of our reporting. And so I think that the primary takeaway here is that we can sort of stratify members that have a greater than 20% likelihood of certain high costs or high risk events, everything from a hospital admission to an emergency room visit to diabetes and so on. And I think that's really important. I think it's pretty clear that emergency room visits are often going to be a higher figure, and there's only so much you can do about that figure. But what I do know in some of the analysis we've done with claims reporting so far and with APH is that if we focus on diabetes, for example, there are 61 members that have a greater than 20% likelihood of this event in the next 12 months. And so what that means for us is we can look at what the typical per member per year spend for someone 12 months prior to a diabetes diagnosis looks like. And that's typically about $2,000. And we can look at what their per member per year spend is 12 months after the fact as well. And it climbs all the way to closer to $18,000 per member per year, which is pretty substantial. And so what that means is if we look at that figure of 61 people and we consider how much money could be spent on closing certain gaps with members who are pre-diabetic and could become diabetic, that helps us understand from a Virgin Pulse perspective, how can we serve up tools on the Virgin Pulse platform, or how can we recommend new partners for you as the Washoe County Insurance Committee or to the rest of the team to support in those members who are pre-diabetic or even become diabetic to try to support those costs as well. And so that's really at a high level some of what I wanted to showcase to you that we're doing with reporting from a claims perspective on the Virgin Pulse side. And so we've covered quite a bit today. We've covered a well-being focus. We've analyzed some health information and some claims reporting. And so with that being said, I'd love to pause there and see if there are any feedback, any questions for me today.
Any questions? Jeff, go ahead.
Thanks. So a lot of great information here. So thank you for your presentation. So this is the reporting. So what do we have to do next to put this to work to help our plan members?
Sure. Great question. So what we can do next is, well, I would recommend getting my colleague back when he returns from he's unavailable to meet with us today, to dive a little deeper into some of the rest of this report with perhaps you all, perhaps the administrators of this program. I work most closely with Laura to evaluate. Typically, I try to take a 6 to 12 month plan of, okay, we want to try to not only have general engagement, which is something that we're accomplishing, but we want to have more targeted engagement as well. And that could be at the surface level of the HRA, which is, okay, we're seeing physical activity as a problem, stress as a problem. When we move the needle and we focus more on the claims areas, that allows us to focus on something, diabetes, for example, where there are certain content channels that are already accessible in Virgin Pulse that we can highlight. And you may have partners that already bridge certain gaps with diabetes that we can highlight as well. And I can also showcase to you of our preferred partners that we already work with diabetes, of which there are many, some of them that might help you to plug into your program and close gaps around those areas. So it really depends on if you agree with some of my interpretations of where risk areas lie, where can we target engagement month over month or quarter over quarter ongoing. Does that help answer your question?
Yes, thank you.
Any other questions or comments? Okay, no more questions. Do you have any final thoughts, or if that's it, thank you very much.
I'll say just one more thing. It was really great to see the Included Health presentation and some of the product roadmap and exciting things they have going on. That's a great example of something that, if that becomes more integrated into your program, that Virgin Pulse can aid in that type of integration. We have a benefits navigation hub that it could really strengthen integration with other partners of yours as well. So that's something that came to mind for me today. And also as well, I didn't dive too deep into our own product roadmap today, but would love to do so at a later date as it makes sense.
Okay,
Otherwise,
thank you very
those are all
much.
my comments. Thank you so much for your time.
Thank you very much. Appreciate it. Yeah, it's been a while since we've had an update on that, so thank you. Okay. 2.08 is the approval of the minutes of the March 30th. Did we skip something? Oh, I'm sorry. I put a check mark next to it. Okay. 2.07, discussion of the Washoe County School District Group Insurance 90-day benefit waiting period. This is for discussion. Go ahead.
Okay, this is Laura Thurston for the record. I brought, I have given some information verbally. I've brought a little of that on physical form. Sorry, it did not get through to the email. And Dawn, you are correct. Mr. Mathers is here to talk about money. I'll go through this briefly just to describe what I'm handing out here. 1, 2, 3, 4, 5. And then we'll let Mark join in here really quickly. So you'll see the first couple of pages I know I've mentioned quite a few of these, but we have gathered just per your request yep. Sorry. Everybody has one. And if anybody in the public out there wants one, I have more. But you'll see the public entity benefits start date. So for example, we spoke about Washoe County being 90 days, City of Reno 91 or 90 days, etc. I have spoke about these before, but this is just for your reference. And then we also start with all the school districts that we could find. I think we found most of them, maybe not Mineral County. But specifically, we dove a little bit deeper also into Carson City School District and Clark County. We're kind of a unique county. There's nothing that really compares apples to apples, right, in Nevada, but these were kind of the closest. So you'll see some data points there. So for example, Carson City School District is 30 days from hire is with their benefit start date. They are they're smaller than us. They have about 700 employees, and they also hire in batches around 25 to 30 people. And within that, they probably hire about 100 to 200 employees per year, is what they're telling us. Also, all of their employees have to attend an orientation, and their benefit sign up is only online, and they don't offer paper at all. They also have the ability to offer a conference room for everybody to go and actually sign up online. Clark County, I'll highlight that as well. They're the first of the next month after the start date. They're also completely online. They have an online portal. They don't accept paper forms. All benefit changes and documents are uploaded through their portal. They have a 30-day window in order to sign up for benefits. They don't allow late enrollment. And they also have an online self-paced orientation only. So those are the two districts that we thought were most like, if you can even call it that, to us, that we dove into and to just kind of explore their processes a little bit more and see how they're implementing a shorter time frame. If you go to the third page, to save paper, I stuck this here at the bottom. Some data points that we have gathered, and again, it's not completely apples to apples. I think when Emily was here, she spoke about how it's the data gathering for us is it's a lot of more of a heavy lifting, right? So it's going through pages of items since we are still paper versus actually looking at reports. So what we found from August 2021 to February 2021, we had 534 new hire eligible employees that were eligible for benefits. Out of those people, 9 of those new hires left within 90 days. We had that question. I don't remember who brought it up, but it was there. So we had 9 people leave within the first 90 days of their hire at that time. Through a different period, October 2021 through March 18th, 2022, we had of 274 new hire eligible for benefits, we had 30, which was 11%. And I think I brought this up before, that we did not receive their information, meaning we did not receive, and it's called what we call insurance eligibility form. That happens for lots of reasons, but again, a large reason is our Business Plus program update had some glitches in it, and so we didn't receive some of that information. And then also, if you look down towards the last bullets, 113 of those people we received within 4 days or more after the start date. Of that 113, 16% of those, 43 of those people were received 15 days or more, and then the 6% of those were received 30 days or more. So that gives you kind of some of the data points, I hope, anyways, it's of what you were asking for, where we are. My biggest concern when looking at those would be the 11% of the information that we're not getting at all currently, which we're working on improving those processes. I have weekly meetings with our IT team and our HR team and improving those and reporting and things like that. And then the last data point, the 6% that we're receiving at 30 days or more, is also we need to work on the improvement points of those as well. So with that, as a quick overview, questions, Rachel?
That first bullet point there, is that supposed to be August 21 through February 22?
Yes.
Okay, thank you.
Thank you. You're right.
Any other questions? I had one. When you said Clark County said that they had no late enrollment, what do you mean? What does that mean?
So currently we allow late enrollees, and it actually happens often for a number of reasons that I won't get into. But so if you miss your time frame, which I think theirs was 30, but I can't remember off the top of my head, you don't get to enroll, and this is not abnormal, but you don't get to enroll generally until open enrollment comes along, whenever that is for Clark County. That's very typical of many entities. We do allow late enrollment, and what that looks like though here is that if you, let's say you enroll day 95, whatever date 95 that is, maybe it's August 27th, you get to start your benefits at the beginning of the following month. So your benefits would start September 1st. We don't retro back them 90 to the 90th day, but they do get to start. So that's a huge benefit, I believe, that the school district offers. The one caveat that's not so fun about that also makes us nervous sometimes about shortening the time frame, at least until we have better processes, is that dependents are not allowed to enroll late. So the employee can enroll late, but the dependents would not be able to add on until open enrollment timeframe. Does that answer your question?
Yes,
Okay.
thank you.
Yep.
Any other questions? Diane?
So, I'm probably behind because I was out for surgery, but so are you thinking about changing the 90 days here or? Okay,
That has been the point of discussion.
okay, but just to add something to transportation, this would have absolutely no benefit to us because of what's going on right now. They hired 5 drivers, 1 state. Doesn't make any difference. They don't care about the 90 days. They don't care about anything right now. Paid same way. They lost 7 while I was gone. So.
Thank you for that feedback.
Okay. So just a quick question to clarify. You said that the right now we allow late enrollments. If we went to 30 days, we would probably still continue to do late enrollments, but we would still not allow dependents to enroll late. Is that correct? They would have to wait till the next open enrollment. That's usually when we have American Fidelity come in and whatever. Our new hires do that directly with their HR techs or when they do matriculation.
I think that would be the assumption. I mean, I'm not the keeper of all those rules necessarily. I just follow all of them. But my interpretation of having that caveat, as I explained it, is that there has to be some point of rule and order, right? We can't keep it open-ended for somebody just to enroll at any point in time. So I think that's a little bit of the draw to keep people to enroll within their 90-day time frame. Yeah. Mm-hmm.
Done.
So I'll throw a caveat in, because my son's 24 and works for a big corporation now, but so I'm taking him through insurance enrollment because that's what you do as mom, right? But their way is you have like 15 to 30 days or 15 days to do your enrollment papers. And if you don't, they just assign you the basic. So no one loses insurance. They don't have to worry about your papers coming in. You just get what is their basic plan, or you can enroll for other plans within that 15 days. So I don't know if that's an option for us to also look at.
Okay. Any other questions, comments, discussion?
I
Eric?
genuinely think overall that bringing it down to 30 days is probably a pretty good idea. I see from my unit is probably being an incentive of some form to attract people in. We've spent some time discussing the potential risks that we might take as a board on taking somebody on. But the insurance fund itself being an internal service fund, I just don't see that being a risk. Whereas, if we have a new employee that comes in and doesn't meet the 30 days, that money isn't spent by the district or transferred into the insurance fund. It just remains in the general fund. I see it almost self-policing because if the new employee fails to sign up for insurance, they're going to face a penalty from the federal government anyways. So, I mean, there's a responsibility in the form of encouragement anyways. So I still see this as being, especially with the list of different public entities in the region that are beginning to offer this as more of, it's kind of a hodgepodge, but there are a number of public entities that are starting to give their benefits relatively earlier than anyone else. So I'm in general pretty in favor of changing this down as low as we can get it.
Other comments or questions? Okay.
So may I, Robert?
Yeah, go ahead,
So
Rich.
it's Rachel Drake. So as I'm looking at this, I really appreciate the specifications on some of the school districts that you were able to gather. Because we have seen a number of our discussions look favorably towards a possible change. And this gives us some idea of where we need to go specifically if we're actually going to consider a change. And so, I mean, is this a spot where we need to stop and consider, do we want to look at late enrollments as a continued consideration if we modify this? Where would we look at a 30-day waiting period, a 60 days, a first day of follow? We have some options here, and I'm not sure if this is the appropriate time for that discussion. So that's what I'm asking for.
I think that we can discuss anything that has to do with this here. We can't make motions. We can't
Correct.
go outside the purview of it. We certainly can talk about anything that would pertain to this type of benefit change. And if you have questions and we need further clarification, could bring that back. Go ahead, Mike.
What's the update on the online portal project? Did I miss that?
So the update is we're still working through the testing portion. I can't say that things have significantly changed. I'm still hopeful that it will be up and running by the school year. But when I say that, I don't necessarily mean everything will go 100% smoothly, because it'll be our first school year with our large hiring season with a brand new portal. And that's where I really hesitate closing the window, specifically this school year when we are trying to use new technology. So sorry, Mike, I wish I had a better answer for you, but we're still in the testing portion. Yes.
Well, I think it's interesting that Clark County obviously deals with the highest volume of hiring of anybody we know, right?
Yes.
Comparably in a school district. So their whole process is online. So at some
Right.
point we got to get there too. So I think any encouragement we can have to keep drifting in that direction would be healthy and obviously alleviate the manpower problem that you have. But to your point, maybe there is something to be said that this year needs to kind of be a year of transitioning to the long term, because I've been advocating for a 30-day period also for administrative hiring. So maybe it is possible, to look at this a little bit different, that if we can get the online portal going this year, get it up and going, with the plan being the next year, a solid reduction in days once online portal's going. I don't think we've really looked at it from that angle.
Done.
So I have to go in a minute, but I was wondering why Mr. Mathers is here, and maybe we could go to that before I.
Yeah. Let's.
Sorry, I have to
Go
get
ahead.
to a rehearsal in Carson.
Hey, you're up. How much does it cost? No, I'm just kidding.
I mean, Laura, do you want to tee this up at all? Or you want me to, I mean, I want to make sure I clarify things for you all, but let me start then. My understanding is that your understanding is that the district's general fund has been paying or is paying the health insurance fund for the first 90 days of coverage of new hires, even though there isn't actually health insurance coverage of new hires during the first 90 days. And so I think the impression that the committee's had, based on my understanding, is that this is somehow a zero cost to the district from moving from 90 days all the way up to zero or the first day. And I want to correct that understanding for you. These are general fund resources, and we do not pay for the first 90 days of a new hire's health insurance coverage. So the cost of what you're considering is significant. It's a general fund commitment that falls under the purview of the Board of Trustees. So the costs obviously can vary year to year depending on how many new hires you have, but it has that cost would exceed, based on our estimates, could exceed more than $1 million per year. So it's a significant resource of the district. As you, I'm sure, know, there are many priorities in the general fund for many things. I think our board has recently kind of laid out very clearly that compensation in a number of areas for our employees is the first priority. So that is where we've certainly taken the budget, as Mr. Bozzo knows. But I just wanted to make that clarification because I think there's been a misunderstanding. To do this would be a general fund impact, again, of potentially more than $1 million per year. And we don't have any plans to do that in our budget.
Go ahead, Eric.
I don't think we were under the impression that it was paid during that 90 days, but as a follow-up question to your statement concerning that 90 days, are those allotments or those FTEs budgeted? Let's just say if we had a teacher allotment, that first year, is that budgeted at 1 year minus 90 days?
That's right.
Okay. And then any subsequent would then be at 12 months out of the year. Is that accurate?
That's right.
Other questions? So it would be significantly less, obviously, if we went from 90 days to 60 days, less than going to obviously to zero. So, you're talking about $1 million if we went to zero, and probably half of that if we went to 60 days. Is that what you're? And of course, it's going to, every given year is going to be different.
It's going to vary, something like that. I want to confirm to you that $500,000 is still a significant sum. So.
Yeah. And how, we got 500 open positions that we're not paying benefits for right now either. So, that's, that includes. Yeah. Okay.
On that one.
Go ahead,
I think that's an interesting question. So I guess I was a little bit under the impression opposite of your point that, if we had X amount of dollars allocated to a year one salary and benefits, that money was just in A, we move it to B through the process. But to your point that it's not budgeted for the first 90 days. So help us understand what does happen, say an employee, let's just make up some scenarios, early separation mid-year after we'd already budgeted salary and benefits for them. And let's say they left 6 months early, where would those funds go?
So we budget by position. So if there's a person to take that position the next day, obviously there's no savings.
Sure.
But we recognize that it's impossible for an agency our size to keep all positions filled every day of the year, for the entire year. So a number of years ago, we started accounting for those salary savings based on vacancy savings and other factors in the budget so that we wouldn't over budget salaries and benefits. So we do account for a certain level of vacancy based on, kind of historical vacancy factor trends. So when someone leaves, there is a savings until a new employee is hired into that position, but we already account for that in the budget. Again, based on historical experience. We just know we're going to have those kind of period lags for when you can hire. And so we account for that.
Okay. Any other questions? Go ahead, Rachel.
So if we're basing things off of historical numbers, and we are in a year, 2 years, where we are far beyond historical numbers of early separation, of unfilled positions. So what you're telling me is that there is some accounting for those things in the budget, but probably not to the level that we're actually experiencing.
So good question. We had this discussion with our board in February in a budget work session. And certainly we have seen higher vacant positions because of the labor market recently. And so there was a discussion about that fact. The if the suggestion is that one might ask, well, why don't we just go ahead and book that higher level of vacancy savings? And the problem is, if this is an anomalous period due to inflation or the labor market or housing prices or what have you, if we started booking that higher level of vacancy savings and then we were able to fill positions at the historical level, now we've got a real problem. Now we're going to overspend our budget, which is against statute. And so now we would need to go back to the board, ask for more money that may not exist. So we're really conservative about how we estimate those vacancy savings, because if we, again, overestimate vacancy savings, we're going to overspend the budget, which will mean a hiring freeze or other actions we'll need to take. It is so, what we're seeing, again, is subject to great debate, right? Is the Great Resignation kind of a permanent or near permanent thing? Even if it isn't, is our region kind of going through transformation, based on higher housing prices? Or will we return to, I hate to say it, but we've heard talk about a recession. If a recession comes, do we see a return to people who want public sector jobs and we reverse all of this? We talk about this a lot. We'll continue to talk to our board about those kind of trends. One thing we have done, and this was discussed on April 12th, is to start to recognize that in certain areas, we actually don't think we're probably going to ever be able to, I don't want to say ever, we can't see in the near future our ability to fill all budgeted positions. And so, as you may know, transportation is one of those areas where we don't think anytime soon we'll be able to fill all 303 budgeted positions. And so what we have done with the board is to present an option, and they approved it, where we reduced the number of positions in our transportation department to a service level we think is palatable to the public, but also at a staffing level where we actually think we can hire all those positions. And so we reduced more than 40 transportation positions, and we're using those savings to begin collective bargaining for compensation increases in critical areas. So we've kind of done what you're suggesting, which is let's just recognize reality, at least in those areas where we've been hurting for a while. So it's an ongoing conversation and analysis we'll continue to have with the board and internally. But again, we want to be conservative and cautious in how much vacancy savings we book, because if you overextend yourself, you've created a real budgetary and fiscal problem. So it's very hard to go back. Yep.
Let's have a quick follow-up to that, Mark. If the the vacancy savings exceeds what you booked, as you say, or budgeted for, what happens to that difference?
Yeah, those salary savings would revert to the general fund's balance.
Okay, got it.
And be available for, one-time uses or just as a reserve against, again, a worsening economy when that happens.
Does that usually happen after the fiscal year closes?
The savings accrue throughout the year, but then, yeah, we recognize those savings and report on the savings at the end of the fiscal year. That's correct.
Okay, that makes sense. Thank you.
Okay, any other questions or comments?
Talking about school budgets, or does that have to be?
Go right, no, just kidding. Rachel, within the purview of the item.
I have lots of financial questions.
So when we first started talking about this, we talked about looking to make perhaps a motion with this related to our May or June putting together everything final. What do we need to do on our end to change this item, which is going to be a consistent item on our agenda, to a item for action or possible action?
I think it can be made an action item. Certainly at any of the meetings that we have, we can make a motion. We would take that motion. If it passed, then it would go to the Board of Trustees for consideration at that point. So it could be an action item on any of our agendas.
Okay. So can I request it be an action item on May's agenda
Yeah,
or for possible action?
yeah. Are we looking at numbers for May for
Yeah.
rates?
Yes. Okay.
So-
So that can be part of that discussion.
Yes. Sorry, I didn't know you were
Yes, it
looking
can
at
be
me.
part of that discussion. And like I said, if this committee makes that recommendation, then that would then go to the superintendent and then to the board of trustees. Typically in the past, even like when we do rates, usually the chair and any committee members that want are usually at that meeting to answer questions to the board if they have questions as well. And I'm sure staff would be there to answer questions and talk about the fiscal impacts and how to do that and how it's going to impact. So, yeah. Just to kind of give you an overview of how it works. And the board may not have it on, if we did this in May, it might not end up on their agenda till June or whenever. I mean, it doesn't happen immediately.
Just kind of a generalized statement, and of course, now that Dawn has left, I kind of like the idea in general. Maybe we can take some more discussion on about potentially doing the auto enrollment for the primary new member into a PPO plan or whatever we deem, what that conversation might look like, or if there is an impact of some kind. But I did kind of like that idea that, okay, fine, if we actually do consider to bring this down to 30, 60 days, whatever, and we've been concerned about the action or onus on that new member to actually engage. If they don't, I think it's kind of not a bad idea if we have a preset program to do something for them. I think there should be more discussion on that. I kind of like that idea.
The one difference that I noticed that concerns me, but it's a little bit, is that if we say went to 60 days and John signs up or forgets to sign up and we put him on that particular program, and then 75 days realizes, because he's no longer has 90 days, oh, I wanted my son and daughter on the program and we're not taking late enrollments on dependents, he would have to wait till the next open enrollment for that to happen. Because right now they have 90 days to get all their dependent documents and everything in to add dependents. And I know that some of those things are, like if they're adoptions and things like that, there's papers they have to have. And if we move that to 30 days or 60 days, that would reduce the amount of time necessary. I don't know. I don't have kids. I don't know if that would be difficult for people to put together, but.
Yeah, and I mean, we'd have to be thoughtful around that. Yes, it would also impact the fund, right, too, because we have people who are enrolling who may not even know they're being enrolling, and now we're pulling contributions and things like that. But the other thing is we do have people who elect not to enroll in our insurance, and there's usually a purpose behind that. So if they're on their spouse's insurance or something like that, and we enroll them, we're now considered their primary. And so we have just switched their coordination of benefits without them potentially knowing or wanting that. So we just need to put some thought around that as well. Yeah.
Absolutely. And actually, I appreciate that input only
Sure.
because I came from the state too, where we didn't have an opt-out program. So
Okay.
obviously I wasn't aware of that particular portion too. And that's great insight. And that's the exact kind of conversation I want to continue.
Okay.
It is true, though, when people opt out, they also opt out of all of their benefits. They can't just opt out of the insurance, so they opt out of all of the other benefits as well.
So just to add a personal experience with that, my spouse's insurance does if you don't sign up, they automatically enroll you. And so, yes, that requires an awareness of what's going on and how that is being handled with your family. But they would have the same notice as you need to enroll or this is going to happen. So we would need time to, of course, to make those documents. But I agree. I think it's a very solid, and we're talking about if we ignore the 11% of people that we lost somewhere along the lines, we're talking about 6% of people that signed up after 30 days. And so this is a very small group of people that are enrolling late. And most of our new hires are enrolling within that early timeframe.
I just have a quick question. Normally, when we're talking about things like rates and stuff like that, we're talking about stuff going into effect in January of the new plan year. This is because this has to do with our hiring time, which is actually May, June, July, and August, our main hiring. If we put this into effect, or we make a recommendation to put this into effect, this year would be, I don't even think it'd be necessarily possible, but if we made a recommendation that we did it for the following hiring season, it wouldn't go into effect in January but we made the recommendation that it go into effect, say, starting with that hiring season of May, June, July of the next year. So that would give HR a year and a half potentially to figure out and get those papers and get all of those and work out processes and get the board's approval and look at what the cost impacts would be and give that lead time of a year and a half rather than trying to, say even January 1st at this point, I think would be pushing. At least that's my gut feeling. Any other thoughts? Okay, seeing none, we'll go ahead and go to 2.08, approval of the March 30th, 2022 minutes of the Group Insurance Committee. And thank you very much for being here. We appreciate it. Committee, and I'll take a motion. I was not here, so I am not going to comment on those minutes.
For the record, Jeff Balls, I had 2 changes to the minutes. Item 2.01 references Mr. Kerr. Is that supposed to be Mr. Barnes? It's the, okay. And then, sorry, item 2.08, approval of the minutes from the prior meeting. The change I had requested was, it looked like it said who instead of how. So it was just the one word that was supposed to change. So that's all I have.
Okay. Any discussion, other discussion? Someone like to make a motion to adopt the minutes as presented with the changes? Yes, go ahead.
Tony Marestio, I move that we approve the minutes with the changes.
Jeff Boswell, second.
Okay. Any discussion? Okay, without objection, we will file the minutes as adopted. Any objection? Okay. And 3.01, public comment. Is there any public comment? Okay. Did you want to comment? Okay. 3.02, announcements of the next meeting, May 25th, 2022, 4 p.m. Same bat time, same place. And 3.03,